a trend in the country of too many patients are getting preoperative radiotherapy because they really don't need it. If you do a TME for a T2 N0 tumor, local failure rate is less than 5%. You don't need radiotherapy. So that's the problem. And that's a problem that's not going to be possible to solve. MRI probably stages patients as well or better than ultrasound. I predict that in the next decade, MRI will become standard of care for staging these patients. The latest controversy, again, I'm running out of time, is what to do with the complete responders. This is an increasing, I don't want to say problem, issue. The preoperative radiotherapy is so good that about 20% of patients will get it and have no viable tumor when you take their colon out. So the question is, do these patients need postoperative chemotherapy? Or even more controversial is maybe they don't need the rectum out at all. Now, what are the data on that? If you give preoperative radiotherapy, take out the rectum, and find no cancer in the specimen, that patient has a local failure rate that's essentially 0. They have a cure rate of about 90%. Okay? And for the most part, systemic chemotherapy improves the survival rate by 30%. So if you have a 10% chance of dying, that means it's 90. It takes you down 3%. So 30% risk reduction achieved adjuvant chemotherapy would take you down to a 9% chance of dying to a 6%. Is that worth the cost and toxicity? Most of us feel it is, but it definitely is worth talking about. What about the wait and see approach? There was a group in Brazil several years ago published a series of about 30 patients who had complete responses to neoadjuvant treatment, and they didn't operate on it. This was heresy at the time, and they reported there was